Today we are going to talk about mechanical ventilation, modes and dyssynchronies. We had two prior seminar on ventilation. The first one being non-invasive ventilation 2 weeks ago. Last week we spoke about mechanical ventilation, the general concepts. Today we will talk about modes and dyssynchronies. First, modes. The most common modes are volume control, pressure control, both control and assist, pressure regulator volume control called as PRVC, synchronized intermittent mandatory ventilation SIMV, and airway pressure release ventilation APRV. It has been used more and more, especially in patients with ARDS. The other modes has been shown more promise, especially in terms of patient ventilator asynchrony and also in weaning modes like NAVA, neurally adjusted ventilator assist, and PAV, proportional assist ventilation, and ASV, adaptive support ventilation, and smart care PS. So we discussed multiple modes, but the two important parameters in all those modes is set by clinician or providers. One, FiO2, number two, PEEP. Let's talk about FiO2 first, followed by PEEP. FiO2 helps with the oxygenation. It also has side effects. Number one, absorption atelectasis. What does that mean? When you inhale atmospheric air, it has 21% of FiO2, and the remaining is primarily nitrogen and other gases. Only the oxygen is involved in the gas exchange process. The remaining portion of the air is inert gases, and it helps keeps the alveoli open, along with other biological things that happen in alveoli, like surfactant that keeps the alveoli open. The oxygen also causes free oxygen radicals that can injure the alveoli. There has been data showing hyperoxia associated with mortality in sick patients. So how to maintain FiO2? What is the safe oxygenation in sick patients? When you keep PaO2 between 60 to 100 and saturation 90 to 96, and you can avoid most of the side effects. That oxygen goals may differ in different clinical entities. For example, in ARDS, we can tolerate even lower saturations like 88 and corresponding PaO2s. I want to show you two data available in the last 15 years. One is association between arterial hyperoxia and in-hospital mortality. This study was done in patients who had cardiac arrest. There are two groups. One group received normal oxygen, other group received hyperoxygen, meaning 96 and above. As you can see, there is mortality in hyperoxia group when compared to normoxia, and the statistically significant. As a result, when you are resuscitating, hyperoxia needs to be avoided. The second paper published in 2024, they compare liberal and conservative oxygen therapy in patients with ARDS. Let's see the result. In fact, the conservative oxygen did worse than the liberal oxygen group, but the difference is not statistically significant. As a result, avoiding hyperoxia in patients with ARDS did not show any benefit. The second variable the clinician set is called PEEP. The idea of keeping PEEP in all those modes to keep the alveoli open, and also it prevents the injury to the alveoli, and it improves oxygenation. And it comes with side effects because it has the effect on the right ventricle, it has the effect on the left ventricle, and also it has consequences in organ perfusion and functions like especially kidney, GI, liver, and cerebral circulation. So what is the optimal PEEP? Because PEEP is necessary, what is the optimal PEEP? It has side effects. The PEEP should be between lower inflection point and upper inflection point in flow volume curve. It should not exceed the upper inflection point. If it exceeds, what happens? It increases the right ventricular afterload and associated pulmonary hypertension, cardiopulmonary, so on and so forth. If it is lower, that also not good because it won't keep the alveoli open in proper oxygenation, so on and so forth, cannot be kept up. And the PEEP has to be optimal to keep the functional residual capacity to promote hemodynamics and also avoid the detrimental effects from the PEEP. As we spoke earlier, it has effect on the heart and also it affects on the kidneys, liver, gut dysfunction, liver and gut, and also the cerebral circulation. The effects are a little bit different in each and every organ perfusion. As we know, it improves right ventricular preload and afterwards it increases the right ventricular afterload by increasing the PEEP in a higher amount. By doing so, it can cause venous hypertension in kidneys, within the kidneys, that can cause acute kidney injury, and also it has other ways of causing kidney injury by releasing inflammatory mediators, cytokine release, so on and so forth. The same principle applies for gut and liver. In brain injury patients, it has effect through carbon dioxide and also it has effect through hemodynamics. By high PEEP, decreases the venous return from cerebral circulation, thus causes venous stasis. Higher elimination of CO2 can cause hypocarbia that can cause vasoconstriction, thus exacerbate cerebral ischemia. High CO2 causes vasodilation that can exacerbate vasogenic edema. So you have to keep the normocarbia within the strict control when you are treating with traumatic brain injury patients. So let's talk about different modes. The most common being the volume control. It can be volume assist too. Clinician sets the following parameters. We already discussed about PEEP and FiO2. Another important parameter you set in volume control is the volume and the respiratory rate. Whenever you set the tidal volume, what changes? The pressure changes depends on resistance and compliance of the lung. Especially in a dynamic setup, when the patient comes with the severe illness, they can get worse for a few hours or few days, then they get better in few days and few hours. So it is imperative to watch the pressure changes when you set the volume control or assist control with the volume preset. This is a picture assist control and the volume preset. In assist control, there are two modes. The volume control can be intermittent mandatory. That means every breath is time controlled, or it can be time controlled with the patient triggered option. This is called assist control. As you can see here, when the patient triggers the ventilator, because the spontaneous breath, the ventilator delivers the preset volume. When the patient could not able to trigger, that means you have a backup rate. After certain seconds, depends on the respiratory rate you set in. It could be 2 seconds or 5 seconds or 3 seconds, whatever the time may be, the ventilator triggers the breath. As you can see, the preset volume is delivered in both the situations. But the pressure at which the volume delivered differs based on the airway resistance and compliance of the lung. The advantages, it gives a guaranteed tidal volume, stable minute ventilation, ability to specify flow rate, which could be advantageous in setting of high airway resistance. The disadvantages is barotrauma. Worsening lung complaints and high resistance can cause barotrauma has been implicated in the mortality and prolonged hospital stay and prolonged mechanical ventilation. I have to explain two pressures at this juncture. One is peak pressure, simply the highest pressure observed in a given cycle. The second one is plateau pressure. It's measured by performing an inspiratory hold maneuver. That tells you the alveolar pressure at that point. When there is a large differential between peak and plateau pressure, that tells you there are increased resistive forces. When there is a small differential between peak and plateau pressure, that tells you we are dealing with diffuse alveolar disease. As you can see in this picture, the highest pressure recorded is called peak pressure. When you do the pressure with inspiratory hold, it measures the plateau pressure. The difference between peak and the plateau pressure tells you resistive pressure in that particular patient. The algorithm follows like this. When there is elevated peak pressure, do an inspiratory hold. If it is elevated, most likely we are dealing with the complaints problem. That could be pneumothorax, Auto-PEEP, pulmonary edema, pneumonia, ascites, and pleural diseases. If the plateau pressure is not elevated, we are dealing with airway resistance problem like kinked or occluded endotracheal tube or bronchospasm. Auto-PEEP. When the patients do not fully exhale before the initiation of the next breath, what happens? Auto-PEEP builds. Higher and higher pressures are required tidal volume. It can lead to air leak syndrome and decreased venous return. Auto-PEEP is measured by end expiratory hold maneuver. The total PEEP measured at the end expiratory hold should be equivalent to the applied or extrinsic PEEP. If the total PEEP exceeds the extrinsic PEEP, that means there is an auto-PEEP is building up in that patient. That happens when there is a severe bronchospasm or because of inappropriate ventilatory settings like tidal volume, respiratory rate, and the prolonged inspiratory time or shortened expiratory time, so on and so forth. The common mode is pressure control. It can be pressure assist too in assist control modes. We discussed the provider sets the following parameters discussed about the PEEP and the FiO2. So the important parameter is inspiratory pressure, I time, and respiratory rate. As we discussed earlier, whenever you fix the preset pressure, the delivered tidal volume changes based on resistance and complaints of the lung. As you can see, this is an assist control mode. That means certain breaths are spontaneous, meaning patient triggered. Some breaths are ventilator delivered breaths. When the preset value, when the patient triggers a breath, the preset pressure being delivered. When the time trigger breath, the same preset pressure is delivered to the patient. Because of the change in the compliance, the delivered volume changes. So whenever you preset pressure, make sure you monitor the volume, and monitor the volume doesn't cause volume. The advantages of preset pressure is, or pressure control or assist control pressure control is, airway pulmonary pressure is never exceeded because you preset it. So risk of barotrauma is minimized. And another advantage of having pressure control or pressure assist is the patient can control their inspiratory flow rate. The airflow increase in proportion to their inspiratory effort, improving patient comfort and minimize patient ventilator dyssynchrony. But the disadvantage is the delivered tidal volume can vary. Excessive tidal volume can cause volutrauma. Decreased tidal volume, as happens with the decreased compliant patients, they can get less tidal volume as a result, poor ventilation, carbon dioxide retention, and ventilatory failure. Pressure support is the third most common. I often use as a weaning mode than initiation mode, but in some conditions, pressure support alone may be necessary. What are the settings the provider sets for pressure support? PEEP and FiO2 we already discussed. Other one is what is the inspiratory pressure? And some settings you can fix inspiratory flow rate too. But the flow and the respiratory rate are determined by the patient, because every breath is patient triggered, because it is not a time cycle one when you do a pressure support. As you can see here, every breath is patient triggered, and the ventilator delivers the preset pressure. The volume changes based on airway resistance and the compliance of the lung. As we said earlier, it is used in weaning patients of mechanical ventilation. But in order for the pressure support to work, the patient has to breathe. So having a depressed drive, the patient cannot able to trigger the breath, or when there is a high oxygen consumption or elevated airway resistance, they are not appropriate candidates for pressure support. In other patients, yes, one can use pressure support. Other commonly used mode is synchronized intermittent mandatory ventilation. The support can be either volume control or pressure control. These are our time control cycles. The assist cycles can be either pressure or volume. Clinician sets PEEP, FiO2, and also in case of volume support, volume, or pressure support, pressure, inspiratory pressure, and the rest. So whenever you use the inspiratory pressure as a preset, the dependent variable becomes volume, vice versa. And the volume is a preset, the pressure becomes a dependent variable. This is the SIMV volume control with pressure support. So what is synchronization? The patient breath or the ventilator synchronized with patient breath. The ventilator recognizes the patient breaths by changing the flow or changing the pressure in the airway system. Most of the modern ventilators have two sensors, both flow sensors and pressure sensors. So, for example, if the patient is supposed to get one breath every 5 seconds, the ventilator waits for the 5 seconds. In between, if the patient triggers ventilator, gives a breath. That is called synchronized breath. Then it will wait for another 5 seconds. If the patient does not trigger breath, the ventilator gives a breath. That is called mandatory breath. In between, the patient can take breaths too. Those are all called supported breath. That time, the pressure support you set becomes active. Oftentimes, it delivers, we give lesser support than the mandatory breaths. As a result, the volume delivered would be much less. As you can see, the volume flow, it is synchronized breath, the preset volume, what we anticipate, it is mandatory breath. These are all supported breath. It's synchronized. This mode kind of helpful in preparing the patient for weaning, and also it helps patient with patient ventilator dyssynchrony or asynchrony. It really helps. It reduces the level of sedation exposure. So definitely it is much better than the intermittent or continuous ventilatory modes, what we have discussed before. Another addition is pressure regulated volume control. I want to dispel one thing. This is not a volume control mode. It is a pressure regulator mode. Time controlled. The clinician said, PEEP and FiO2, we already discussed. Other things we set is time cycle. What is the respiratory rate? What is the pressure? And what is the volume needed? So whenever you do that one, the dependent variable becomes volume. I typically see in pressure regulator volume control, make sure the volume was set is being delivered, and also the pressure doesn't go up high. Since this is dual mode, it pretty much controls what the volume being delivered, because it's preset, and also it regulates the pressure. I'm going to explain to you in the next slide. So what does it do? It gives a first breath. The ventilator gives a first breath in this mode. Then it identifies resistance and the compliance of the system. Based on the preset values, it gives such a pressure so that the preset volume is achieved, and keeps doing every breath and reanalyzing the data and deliver appropriate pressured breaths in subsequent breaths. So it is like having a respiratory therapist miniature version within the ventilator. He monitors every breath instead of every 2 hours or every 3 hours. It is very advantageous. It improves the patient-ventilator asynchrony, decreases sedation, decreases the length of stay, and decreases the mechanical ventilation, thus decreases complications. Another most common mode, especially in patients with ARDS, is APR, airway pressure release ventilation. The trigger is a time the clinician sets pressures. It's kind of different kind. I'm going to explain to you in a bit. And of course, PEEP and FiO2. Dependent variable is tidal volume. Whenever you preset pressure, the volume changes based on the compliance of the lung. So question is, when to use PRV? There are two concepts, one lung disease and two lung disease. This particular one shows the one lung disease wherein probably the patient has either pneumonia or emphysema or some kind of pleural disease. In these patients, APRV is not a good idea to initiate. The reason is APRV improves hyperinflation of the lung. So the unaffected lung will be overinflated or disproportionately inflated. As a result, it can worsen the condition. So this kind of patients, we do not like to use APRV. On the other hand, the next side has a bilateral lung disease with hypoxemic respiratory failure. This is an ideal candidate for APRV. There are 4 variables we use, which is different from other modes. One is P high. This is P high. In other words, it is an easy way to explain APRV is keeping a high CPAP and intermittently you release it. That is the easy way to understand. The high CPAP causes lung alveolar recruitment. The sudden drop can help to eliminate carbon dioxide. Another important positive thing about airway pressure release ventilation is patient can breathe in between. Spontaneous breathing is unhindered. So this is called high. And P low is oftentimes set at 0. Some people do too. Another important parameter you set is T high. How long you keep holding the CPAP. Typically 2 to 4 seconds. When there is hypercarbia is a problem, just do like less amount of time, like 2 seconds. Hypercarbia is not an issue. You can go to 3 or 4 seconds. T low is how long you can trap the peak expiratory flow rate. Typically 0.4 to 0.6 seconds. Start with 0.4 and change as needed based on oxygenation and the blood gas. It is very important in a bilateral hypoxemic respiratory failure. Airway pressure release ventilation definitely helps in keeping up the alveoli recruited. As we discussed, there are 5 settings, excluding FiO, 4 settings: P high, T high, P low, T low. P high, analogous to CPAP, the high pressure set with 2 centimeters of plateau pressure. Oftentimes, most of the time, we initiate volume control with the pressure support. When the hypoxemia becomes a major issue, we switch. So we kind of use the same plateau pressure as a P high pressure. P high, as I said, it starts with 2 seconds, especially when you are dealing with hypercarbia. P low often set at 0, and T low start with 0.4, 0.5 seconds and titrate up or down based on how the oxygenation. As I explained to you, continuous CPAP and a release pattern. During the release time, the carbon dioxide is eliminated. As I said, the patient can spontaneously breathe in between the releases we set. Proportional assist. There are other 2 modes we are going to talk about, is proportional assist and NAVA. They are very good as far as ventilator synchrony and also very good weaning modes. The unfortunate thing is you need to use that particular ventilator in order to have those 2 modes. In fact, I'm going to discuss about the proportional assist ventilations where you set only the PEEP and FiO2. The patient determines flow, pressure, trial volume, breath rate, and minute ventilation. As a result, it doesn't have barotrauma or volutrauma. It differs from other conventional modes. In conventional modes like volume control, PRVC, VC plus, and volume support, when the patient effort improves and the patient ventilator support decreases. In NAVA and PAV, when the patient effort increases, the support increases. That means the patient is not an air handler. Patient is not dyspneic. The patient is not fighting the ventilator. As far as patient ventilator synchrony goes, these are the 2 modes one can choose. But unfortunately, it's available only in certain ventilators. It's proportional assist ventilation. When the patient needs, it is an esophageal monitor. When the patient needs inhales, you wanted to have higher intrathoracic pressure, he gets it. As you can see, increased mean airway pressure. When the need is less, it is less supportive. That's all the patient needs. So it's proportional to the patient needs, proportional assist ventilation. Next one is NAVA. Here the trigger is electronic activity from the diaphragm itself. The clinician sets PEEP, FiO2, and of course EADI, and there is a NAVA level. The patient controls trial volume, respiratory rate, and minute ventilation. This is a schema of how does it work. Normally, the respiratory center initiates a breath. Then phrenic nerve conveys it to the diaphragm. Diaphragm contracts, intrathoracic pressure falls, and the atmospheric air goes in. That is called inspiration. When the diaphragm relaxes, the elastic recoil of the lung pushes the air out, which is called expiration. So what does this technology do? It recognizes the diaphragmatic contraction by putting the nasogastric tube in. So as a result, the lag period is definitely improves, and based on the EADI, the amount of oxygen or the amount of air or ventilation needs differ from each and every breath, and the patient controls it. The good thing is the patient ventilator asynchrony is improved and shortens the length of hospital stay and improves the long-term outcomes. But you need to have a special ventilator, special software, and special equipment to detect the electronic activity of the diaphragm. As you can see, when you have a software and the nasogastric tube to detect EADI, you can see the location is correct or not correct. And it also tells you whether to move up or move down. And also you need to secure the nasogastric tube because it can move down or move up so that it can detect the EADI. So you need to monitor all those things when you are in NAVA. And the amount of flow and tidal volume generates based on EADI. So it is a very advantageous as far as patient ventilator synchrony goes, and also to lung protective ventilation. These two modes definitely help VILI, ventilator induced lung injury. And CPAP mode. CPAP modes often I use for weaning purposes, but it can be used in acute cardiogenic pulmonary edema and post-op period, so on and so forth. The clinician sets PEEP and FiO2 and patient control, tidal volume, respiratory rate, and mechanical and minute ventilation. So what are the suggested settings in all those modes? There are two groups we want to group in. One, those patients with normal lungs, for example, patient with pneumonia come in. What are the normal settings? Patient with ARDS, like acute hypoxemic respiratory failure, normal settings or starting settings, initial settings. And patient with obstructive airway disease. What would be the initial settings? Let's walk through one by one. Normal lungs. Normal lungs means either post-operative, a patient with pneumonia, kind of regular bread and butter. Normally, we choose assist control, volume control in those patients. This is an adult value. The respiratory rate is 14 breaths per minute. In children, you have to choose the respiratory rate based on the age of the patient. Tidal volume, aim for 7 to 8 ml per kilo for ideal body weight. If we were to start with 0.4 and escalate it, or start with 100% and wean down. Initial PEEP one can start with 5. Inspiratory flow rate, most of the time the ventilator determines. If it is independent variable, one can use 80 liters per minute. So again, it's an adult value. In children, it will be much less than 80 liters per minute. In patient with ARDS, again, assist control and volume control, breaths 20 breaths per minute value. We tend to give more respiratory rate in order to decrease ventilator-induced lung injury by reducing the tidal volume exposure. In children, again, age-dependent respiratory rate, if I were to start with 100% and wean down as quick as possible, and the PEEP, again, 5, and you have to go up, especially when you are dealing with acute hypoxemia respiratory failure, to optimal to keep the PEEP between lower inflection or midpoint between low inflection point and the upper inflection point, the flow volume curve. Sorry, the pressure volume curve. An inspiratory flow rate in adults 80 liters per minute using decelerating ramp flow. In obstructive disease, again, assist control, volume control, you see the respiratory rates are lower. So important point in obstructive airway disease, decrease the rate, decrease the tidal volume, prolong the expiration time, decrease the inspiratory time. Start with FiO 200 and wean as quick as possible. And PEEP, it's an important element in obstructive airway disease. Dynamic hyperinflation is important concept in obstructive airway disease. What is the optimal PEEP in obstructive airway disease is 80% of Auto-PEEP. Identifying Auto-PEEP is not that easy. Of course, we discussed about end expiratory hold, that will give you a total PEEP minus extensively applied PEEP is Auto-PEEP, right? It's not that simple because it's kind of hard to measure the end expiratory hold. That one, at least for me, it was kind of harder. I typically do 6 to 10 centimeter of water to combat the auto-PEEP. So you need to apply certain PEEP so that you offset the auto-PEEP. SmartCare PS. I do not have any personal experience with SmartCare PS, but model is valuable in certain settings. It's an explicit computerized protocol where the clinician set tidal volume, respiratory rate, and carbon dioxide, end-tidal CO2. As a result, whenever you do tidal volume, the dependent variable becomes pressure. So in this one, number of clinician inputs to alter the ventilation operation. It is very good in patient with traumatic brain injury because it monitors carbon dioxide. So the normocarbia between 35 to 40 can be easily maintained in this particular computerized model. And also it incorporates the night rest, meaning, the other ventilators don't care. Day or night, it does the same thing. But SmartCare PS, it gives night rest phenomena that is incorporated into it. As I said, I do not have any personal experience with SmartCare PS, but it is good ventilator for weaning protocols and also in specific populations like traumatic brain injury. Adaptive support ventilation. This is one of my favorite. I was longing to work with adaptive support ventilation for many years, but anyway, currently I'm using it. It's kind of a little different from other modes. It titrates the ventilator output on a breath by breath basis, similar to PRVC. The goal is to provide the preset level of minute ventilations while minimizing the work of breathing. The clinician set PEEP, FiO2, and minute ventilations, which is different from other modes. Start with 100%, even there is a very sick patients, or you can start with 80%, 60%. When you do the ASV, which is adaptive support ventilation, adjust the inspiratory pressure to achieve the respiratory pattern that minimizes work of breathing using Otis equation. The breaths alternate between pressure control and pressure support breaths based on presence or absence of spontaneous breaths. So the ventilator automatically identifies the compliance resistance and gives enough tidal volume without exceeding the higher pressures. And also it weans on its own. As the lung compliance improves, it decreases the pressure needed or volume needed to deliver the same minute ventilation. And also, as a clinician, every day you see the patient and to decrease the minute ventilations occurred for the patient. It's interesting mode. I love it the way because it kind of removes lots of manual errors that could go when you are dealing with sick patients. Okay, this concludes the mode section of the mechanical ventilation. Second most important is patient ventilator dyssynchronies. Why this is important? Because there are lots of complications associated with patient ventilator asynchrony. Number one, it can increase the work of breathing, ineffective effort, air trapping, respiratory alkalosis, hyperinflation of the lung, like auto-triggering, dynamic hyperinflations, auto-PEEP, alters outcome of weaning, increased level of sedation, confusion about the actual condition of the patient, sleep disorders, longer stay in intensive care, and mechanical ventilations. Most importantly, there are two important things. Mortality is increased, complications increased, and there is a cognitive impairment. It's not talked about that much in post-critical care setting that may be associated with the patient ventilator asynchrony. The patient is fighting the ventilator while the patient is being cared for in critical care units. So what kind of patient ventilator asynchronies? During inspirations, one can have flow starvation. What does that mean? Delivered flow does not match the patient demand. It could be because of insufficient peak flow or high respiratory drive. As a result, the patient can have dyspnea and high levels of work of breathing. It's most commonly seen in assist control ventilation mode. How do you resolve it? Increase the peak flow mode. Keep the flow more than 50 liters per minute. Again, it's an adult value. In children, you need to go up like 2 ml per kilo. Either by direct settings or shorten the inspiratory time to obtain the same volume faster. Second asynchrony is short cycles. The inspiratory effort continues after the end of insufflation. The reason, insufficient inspiratory time or high respiratory drive. As a result, it can cause excessive action of respiratory muscles and double triggering. And again, you see in AC volume mode, what do? Increase the inspiratory time. Because patient needs more inspiration than what you said. Prolonged insufflation. That means continuous insufflation after the end inspiratory effect. The reason could be inadequate cycling mechanism or gas trapping. It results in dyspnea and shortened neural expirations and promote gas trapping. It occurs in AC ventilation, process support, and an non-invasive. Modify cycling to make inspiration shorter. Basically, you need to keep the inspiration short. So you need to identify which asynchrony so that you can either increase the inspiration in certain patients and decrease the inspiration in certain patients, or use the mode where inspiration doesn't matter. Inspiratory time. Reverse triggering. Diaphragmatic contraction triggered by mechanical insufflation. It's an interesting phenomenon. It's a reflex mechanism because the patient is in highly sedated condition. What will happen? It can cause loss of protective ventilations. The monitoring of plateau pressure inoperative because it is reverse triggering happens. The eccentric contractions of the respiratory muscles could happen. As you can see in this diagram, the white arrow shows reverse triggering. It's often seen in AC ventilation. If there is too many double cycling, if the volume is too high, paralyze the patient. If the more sedation is the reason for this reverse triggering, decrease sedation. It's kind of hard to call. You need to really see its trial and error. If you think it is more sedation, decrease sedation and see the reverse triggering goes away. If it doesn't, you paralyze the patient and take over. Double cycles. Double cycles after reverse triggering. Reverse triggering of the second cycle, the reflex mechanism in the highly sedated patients, very same thing like what we talked about before. It gives a double mechanical stress on the lung. It's seen in AC ventilation. Paralyze if tidal volume is too high or double cycling, or decrease sedation. First, decrease sedation and see if it doesn't improve, paralyze the patient and take over. Double or triple triggering after short cycles, so-called breathtaking. Continuation of inspiratory effort after the end of insufflation. It could be because of insufficient inspiratory time, short inspiratory time, or the high respiratory drive. Double or triple mechanical stress on the lung. As you can see, these double triggering on the ventilator is seen in AC ventilation and process support. Either prolong the inspiratory time, increase the tidal volume, asynchronies can happen during expiration too. One is auto-triggering. It's very common. When there is leaks, water in the circuit, excessively sensitive trigger, or cardiac oscillations. So as you can see, auto-triggering happening in the diagram, the waveforms. This can cause dyspnea, misleading information, and severe hyperventilations because the patient is getting breath for each and every trigger, and increased rate of lung stress. It's seen in AC ventilation, pressure support, and non-invasive. How do you resolve it? Inspect the tubing, make sure there is no water log or not obstructed, and check the trigger sensitivity. It may be very sensitive to detect small changes. Gas trapping or auto-PEEP. Next inspiration starts before the end of exhalation. The reason being high time constant. The results, it can cause poor diaphragm function, hemodynamic effects, and ineffective efforts. You can see it in any assisted modes. How do you do it? Decrease the dynamic hyperinflations by increasing expiratory time, decrease the minute ventilation, that means decrease style volume or respiratory rate, ineffective effort. That means unable to trigger the ventilator. Maybe because inadequate cycling, excessive support. If you give too much support, the patient cannot trigger the ventilator. And large time constant and low respiratory drive. As you can see in this pressure time and the flow time curves, the patient wants to breath, but he doesn't get. It will be seen in any assisted mode and non-invasive ventilation. How do you resolve it? Increase the trigger sensitivity, because the sensitivity is too big, so the ventilator doesn't recognize the trigger. Or decrease sedation, or increase expiration time, or increase a PEEP to offset the auto-PEEP. So these are the certain maneuvers. Number one, you need to recognize. Number two, you act appropriately. And third, you monitor, make sure that asynchrony gets better. This concludes modes and asynchrony in mechanical ventilation. I will see you next Sunday at 7:30 a.m. Central or 6 p.m. Indian Standard Time. Thank you so much for watching.